Now, I'd like to go ahead and turn the microphone over to today's presenters, Dr. Scott Walters and Dr. Emily Spence Almaguer. Thank you.
Thank you for the introduction. I really appreciate the opportunity to tell you about what we're doing here in Texas. So I'm Scott Walters. I'm a professor at the University of North Texas Health Science Center, and I'll also introduce Dr. Emily Spence Almaguer, who's an associate professor here, also in behavioral and community health at the Health Science Center. Whitney Hill is our project manager, and she is ill today, so unfortunately she's not going to make it, but I will address her part. And we will make sure and save at least 10 minutes at the end for any questions you might have. Since the caveman days, there have been theories about how to get people to change their behavior. Theories range from relatively crude techniques like threatening, pleading, nagging, to more sophisticated techniques in modern days, cognitive behavioral therapy, solution-focused therapy, motivational interviewing. But they share the commonality of trying to get people to change their attitude or behavior through talking. More recently, computing technologies have arisen that allow people to store and process data. Originally, computer systems weren't designed to change people's behavior. They were designed to help people process data or to store information. But it turns out that there is a corner of the technology market that also changes people's behavior. We call this persuasive technology. As a matter of fact, some behaviors are especially amenable to changing via technology. Technology can do a lot of things that in-person interactions can't do. For instance, they can tailor interventions, they can provide just astonishing fidelity to a model, they can be on all the time, and the ability to scale up to very large numbers. So they're uniquely suited to some kinds of health behaviors. Technology is persuasive in a number of ways. It turns out that for some people, simply monitoring the behavior, getting feedback on how you're doing, for instance, counting your steps on a pedometer. Technology can also provide rewards to people. And it turns out that many of the features of technology, people read human emotions into that. So when technology rewards me by giving a little badge saying I lost a certain number of pounds or I walked a certain number of minutes in that day, people feel similarly about that reward and that praise as they do when a human gives them that praise. So it's very handy. Technology can tailor information based on a person's personal characteristics. So when I log on to iTunes or Netflix or Hulu, it provides suggestions. So it guesses based on my past history what things I might be interested in. Technology can provide key information at key decision points. So one of the most efficient ways to lower a person's speed in a car is just to provide information on how fast they're going. And better yet, if they're going over the speed limit, maybe the number flashes. Or even better than that, maybe it gives a little smiley face or a little frowny face. A very cost-efficient way to change a person's behavior. Technology can help to speed users through a particular sequence. So when I check out on Amazon, I have two options. I can either add the item to my cart, or I can, this slightly darker button, I can buy it with a one-click. And what that does is it means that I'm not going to have to check my basket. I'm not going to have to verify my credit card information, verify my shipping information, the shipping speed, and so forth. It speeds me right to the end. And so it makes it easier for people to accomplish the task you want them to accomplish. In this case, it's the task that Amazon wants me to accomplish is to buy this product. And so the darker orange button is a more efficient way to speed me through a sequence of behaviors that I would otherwise maybe change my mind. And finally, technology has a very good way of surveilling people, of providing information about how people are doing in the real world. So all the way from Fitbit information you might share with your friends on Facebook to something like an interlock that shares whether a person has been drinking with a probation officer. So a number of benefits. B.J. Fogg, who is a kind of a grandfather of this category of persuasive technology, says that technology is basically persuasive in three ways. It can increase a person's motivation to do something. It can help people with ability, or it can provide reminders or triggers in the real world to do something. And most persuasive technology uses these three basic elements. Motivation is a way of increasing the urgency or saliency of a particular action. So some things that we've done in the past is to provide tailored information about, for instance, how people compare to others with regard to their weight loss or their walking or their alcohol and drug use. For instance, if they're in the 95th percentile with regard to their alcohol use, that's persuading to some people. It can provide some risk indicators. So if you're at that particular level, you're now in the yellow zone or in the orange zone or in the red zone. So something, presumably, you're in a worse risk category compared to other people. Or perhaps the estimated benefits of change. So if you're currently smoking a pack a day, and so based on that, your risk for developing oral cancer is 10 times a non-smoker. But if you reduce that to a half a pack a day, then your risk would go down to 5 times. If you reduced it to no more than 2 cigarettes a day, it would go down to 2 times. You can provide different scenarios to people about how a behavior change might benefit them. A key principle here in motivation is that if motivation is high, people will do difficult things. But if motivation is low, people will only do easy things that are right in front of them. There's quite often a trade-off between motivation and ability. The second category of ability is the way computing systems can make it easier to do something. So examples might include helping a person schedule. So what would come first? When would that occur? On a Tuesday, at a Tuesday morning? Resource provision. So who would help you with that? Is there an organization in the world that might work with you in a more efficient way to streamline or organize or provide a sequence of behaviors to make it easier for you? The key principle here is that simplicity or ability should target whatever a person's most scarcest resources are at a particular moment. So if a person lacks transportation, maybe the ability, the thing that is going to make this more simple for the person is giving them a map of bus routes or a train schedule or a bus pass. If the scarcest resource is time, maybe it teaches a person to be more efficient with the way that they use their time, to schedule things better. And finally, triggers are things that remind people of what to do when at the particular time that they want to do it. And in fact, life, I mean, let's be honest, life is full of triggers, all the way from the red light that I stop at so I don't crash into other cars in the intersection, to the beeping sound my car gives me when I get in that reminds me to put on a seatbelt, to my alarm clock in the morning, to oil change reminder. Life is full of triggers. And technology is uniquely suited to providing people with reminders about doing things in a way that humans just plain can't do. So those are the three things: motivation, ability, and triggers. And so the question for us here is whether we can combine these principles of persuasive technology with evidence-based in-person interactions to address more complicated health behaviors. So I want to tell you a little bit about MChat. This is a program that involves three basic elements. We target people in, I should stop saying target. We are working with people. Target makes it sound like we're shooting people. This is Texas after all. So we're working with people in the community who are residing in a housing category called permanent supportive housing. And for those of you who aren't familiar for the different housing category, this is a category of housing that includes a rental voucher and a supportive case management services, access to case management services. It's designed for people who have some sort of debilitating physical or mental health condition. And in our case, more or less everybody in our program has been chronically homeless at some point. And so it's a very difficult population full of just a broad history of disability and trauma and difficulties, as I'll show you in just a moment. And so those are the people we're working with to set health goals and to monitor behavior and encourage people to make changes in their overall physical and mental health. It involves three basic components. So there's an in-person health coach component that I'll talk about more in a minute. This involves meeting with people about once a month, an in-person meeting. At the beginning of the program, we were meeting with people typically in their homes because many of these people are disabled in some way and it's difficult for them to get out. We learned quickly that the home is not an ideal place to meet with people. I'll tell you a little bit more about why that was the case for us. But the health coaches meet with people somewhere in the community now. We use a combination of motivational interviewing and solution-focused therapy. It's a structured intervention to help people set health goals in different areas. There's also the coaching software that I'll demonstrate in just a minute. This is the MChat interface that can provide tailored feedback to people, that can help document their motivation, their plans, their action items. It can also provide for reminders for people, as I'll show you about in just a minute, and help people track their behavior to see their progress. And finally, we have a pot of money that we've designated for wellness incentives. We call these chat bucks. And the idea is to use something a little akin to contingency management, but more structured than that, where people can earn points, really, up to 60 points, 60 chat bucks, which are worth about $60 depending on the item each month. And these are put into an account, and then people have a menu of health items that they can select from. So, for instance, if a person's goal is to exercise more, they might want to think about a pair of walking shoes, or a cane, or a discounted YMCA membership, or a pedometer. And during the monthly meeting, the health coach helps the person to walk through this menu and select an item that might be helpful to them. And this item is ordered right through the interface through Amazon. We place the order, and the item is shipped right to the person and deducted from their chat bucks balance. So you'll see a little bit more about that later. But all these items are pre-approved. The project orders them, and they're shipped right to the person based on whether or not they're meeting with their health coach. So I told you a little bit about the kind of people we're working with. This data comes from Emily's Directions Home data that she gathered for the city of Fort Worth each year. And this is a profile of some of the current conditions that are reported by permanent supportive housing residents. And as you can see, it's a very difficult population. About 3/4 of people in permanent supportive housing, these are our clients, are reporting some sort of chronic health condition. About 2/3 are reporting some sort of substance abuse, and better than 1/3, 38% there, are trimorbid. So they're reporting some sort of chronic health condition, substance use, and mental health condition. It did strike me after looking at this slide a while. I'm used to doing more clinical trials where you're filtering out people who for a particular purpose. So it's just for substance users or just for people who are in a cancer prevention or something. But it did occur to me after looking at the slide that many of the things that we include people based on would be exclusions for most clinical trials. So, for instance, excluding a lot of people for trimorbidity or mental health condition or housing instability or lots of the things that would exclude people normally from behavioral health intervention trials are the very things that we're including people based on. I just thought that was noteworthy. And then another way of looking at it is by asking our residents what kind of concerns they have about different quality of life areas. And so asking people to report whether or not they thought this particular area was a problem for them. And you can see quite a lot of people are reporting that poor mental health, poor social support, a lot of isolation, a lot of loneliness, a lot of disability, getting around, lack of food instability, neighborhood. It's just it's a very thorny issue for us. A lot of these behaviors are wrapped up together. Because of that, we wanted to take a broad approach to health by developing an intervention that targets multiple areas at once. This right here is the 6 areas that we are targeting in the MChat program. You have, starting in the upper left, diet, exercise, social support is the red one on the upper right. In the lower left, you have recreation, and then you have medication, and then you have substance use. So it's those 6 areas: diet, exercise, social support, recreation, medication compliance, and substance use. We intentionally took a broad approach because for many people, these are very much tangled up together. The colors are meaningful, and I'll show you in just a minute what the colors mean. But this is how we would explain it to a person. We would, the very first thing, even before they see the computer interface, is we would hand them a piece of paper that has these 6 areas in black and white, and we would say, so people in this program set health goals in all different areas. Some people decide to set health goals related to diet. So that's changing the kind of food they're eating or the amount of food they're eating. Some people make changes in exercise. So that's moving your body, getting out. It may involve walking or running, but being active. Some people decide to make changes in social support. So that's having good people around them who can help them if they need things. Some people decide to make changes in their recreation, their spare time, what they do. For some people it's reading. For other people it may be going out to a museum or a library or a community center. Some people decide to make changes in their medication. So that's taking a medication in the way a doctor has prescribed. And finally, some people make changes in substance use. So for some people that's smoking. Some people make changes in alcohol or even drugs. As you think about these different areas, what's an area that you've already thought about making changes in? So that's an important principle, is to introduce this menu of options and give the client a first stab at the area they'd like to make a change in. And then based on the colors, what the colors mean is that based on the results of a recent assessment that was just done, the green means that a person is doing probably well in that area. The yellow means there kind of maybe some room for improvement, and the red areas mean that there probably is a lot of room for improvement based on some standard metrics we put together. And so this gives the coach information to be able to steer the conversation and to be able to balance the autonomy of what area the person decides they want to work on with what the system thinks maybe would be the thing that would be most related to their physical or mental health. I'm going to tell you a little bit about the intervention design and what this looks like practically. I'll show you some pictures of some of the settings in which this is done, and show you the interface and kind of walk you through how the in-person component fits with the technology component. So currently we do our health coaching visits here in places like this, on the porch of a house. We do it, our health coaches meet with people in the food courts of malls. They're good places, safe places. Meet with people in the breezeways of apartment complexes. They can't get around. We're in fast food restaurants like this. And the YMCA has offices that we use. They've been excellent partners in Fort Worth. We also have a small office here at the Health Science Center. We encourage people, if they're able, to take the bus and come here and see us and meet with their health coach for that visit. The problem we discovered after meeting people in their homes was some small problems of neighborhood safety and hygiene and hoarding. We also discovered a lot of problems with bed bugs. And we looked all over for a way to address this, but ultimately we had, of our 7 or 8 staff members that were out in the field, we had 4 of them come home with bed bugs to their families, and we had to stop it. We tried different things. When we go out and meet with people in a breezeway, let's say, we take metal chairs. We don't wear loose-fitting clothing. We use an alcohol spray, but it was a real problem. The bed bugs and the cockroaches and the fleas, and it just it wasn't going to work. We did the best we could, and it just plain didn't work. And so now, for most people, we don't go into people's homes. We just simply explain it that way. That we have a lot of traffic. We go in and out of people's homes all day. And it's just, it may not be you, but it may be someone else, and, so we're just going to have to find some other way to meet. If we meet at a fast food restaurant, we'll get a person a drink, a soda or whatever, and then if we meet at another place, we'll give the client a bus pass to meet us someplace off-site. But that's the limitation that we found. This is our little space. Like I said, we have a couple little offices where we can meet people, and when we discovered we were having a issue with bed bugs, you're going to love this, I had to approach my dean and ask him for some space right away right in the middle of our school. You got classrooms really on both sides of this room here. And oh, by the way, we needed to rip out all of the carpet, put in hardwood laminate, seal it up, just like our patient care center, and put in all hard surfaces. Go get rid of everything. So it was an interesting conversation with him. So it's been a lively time. So the basic structure of the coaching visit involves a discussion of motivation, identifying different areas the person wants to work on, and talking about a person's motivation at any given time. And based on that, setting some long-term goals, for instance, some 6-month goals about weight loss or diet or exercise or being around good people or quitting drugs or whatever. And after we set those long-term goals, we talk about short-term action items. So we break it down. What are the first steps that you're going to do to move? If you think your overall progress from 1 to 10 is it a 2? What are some things you're going to do during the next month to move it up to a 3? And we talk about some very small action items and come up with a list before that the person wants to address before their next visit. And then we use the system to set reminders. We can evaluate progress from the last visit and then review progress when we meet with the person again. When we get to the end of the visit, the coaches all have access to a small battery-powered printer, and we're able to print the person out a little summary that they can take with them. We can also set text reminders in the system. So if the person has a cell phone, as a texting-compatible cell phone, they can receive reminders about their health goals for the next month. We'll show you a little bit about what that looks like and how many people are taking advantage of that reminder component. So this is what the MChat interface looks like. You see we blanked out the name and the ID number. This is an actual patient in the trial. Along the top, what you see are the 6 areas here: diet, exercise, social support, recreation, leisure, medication, and substance use. And so you can see the colors for this person. So they're doing well currently in diet, and well in medication compliance, and well in substance use. They are sort of in the middle and marginally with their exercise, some room for improvement, and they're doing poorly in their social support and recreation activities. So this is the reason the fork and knife here, the diet is filled in, is because that's the area that's active right now. When you click on these different areas, it will change and you'll go into the different categories of behaviors. Right here you can see what we call the anchor score of 81. So we used sort of abbreviated standard measures in each of these areas that allow us to determine how well a person is doing at any given time. So currently this person is doing fairly well. Below this anchor score here are these 3 bars, and the fruits and veggies. So the reason why they have an 81 is they're doing well in fruits and vegetables, so eating a lot of fruits and vegetables. And at the bottom, they're eating very little fat. So those are both good. However, they're also eating a lot of sweets, so that's kind of bad. So that puts them just kind of in the medium good range here. This is this anchor score. And as you go through talking about motivation, here's a okay. This is the same person. So all I've done is to just hit the motivation tab right there. So those of you who know motivational interviewing will see this importance ruler. And every time we meet with a client, we ask about, at this moment, how important is it for you to make a change in whatever area this happens to be diet. So at this moment, how important is it for you to think about making changes in your diet and to be able to document the person's reasons. So when you click a number here, this person happens to be at a 10, but when you click a number here, a box will pop up and it'll ask you, the health coach, to type in, to document the person's motivation. So that's what's going on along the top as you move through the different areas that the person wants to work on. On the left side here, this sort of gray toolbar, we're currently on the dashboard, which is the health domain areas. Once you've talked about motivation along the top, there are these different session tasks like goals that you'll see in a minute. What we found was that many people want to set goals that aren't related to any particular domain. So they might have the goal of contacting their sister to be able to walk more. So for that person, it may be about exercise, but it may also be about social support. So many people's goals are not particularly tied to any health domain in particular. They're tied to multiple health domains. So we have a section of goals that we'll show you in just a minute. And then there's an action item and reminder section we'll also show you in just a second. So what I'm going to show you here is this is about a 2-minute, it's a role-played interaction between this. I think this one is me and one of our health coaches. It's a little role-played interaction that shows how the interface would work in this particular section when the coach is meeting with the person and talking about setting goals related to diet. So I'm going to go ahead and move the phone close to the computer so you can hear it, and I'll go ahead and play it. Well, if I were to ask you, like your motivation to make changes in your diet, on a scale from 1 to 10, how important is it for you to make a change in your diet?
It's at an 8.
It's very important.
Yes.
What are some reasons that make it at an 8 and not a lower number like 5 or 6?
Well, it's really important to me because if I had more energy, I'd be able to play with my grandkids. And right now, I'm just too tired to do that. I'm so stuffed when I finish my breakfast or my lunch or dinner that I can only sit in front of the TV, and I don't want to do that.
And you really miss that.
I do.
Being around your grandkids and playing with them, and it bothers you.
It does, a lot, and it bothers them, and I don't like that.
What's another reason? So you said you're in an 8. That's a long way from a 1.
Yeah.
What else comes to mind in terms of motivation to make changes in your diet?
Well, I think I would feel better about myself. So of course, if I'm eating less food, less calories, less weight, I would weigh less. And when I looked in the mirror, I would feel good about what I saw. So really self-esteem would go up.
And so you want to, you're not happy with the way you look now, and you'd like to look better. Your self-esteem is partly in how you're looking.
Yeah.
So that's another reason.
Yes.
So how would you, notice I'm typing here. So I'm just,
Okay.
This is partly for me so that I can remember what we talked about. And it's partly to kind of document where you are, Some of the stuff gets printed out at the end of our visit. We'll print out a little summary that you can take with you. Just, some notes on what we're doing. So so I asked you about that reason, and you talked about wanting to feel better about yourself. How would you describe that?
I would call it increasing self-esteem, increasing level of confidence. Yeah, increasing level of confidence.
So I typed in increasing level of confidence or self-esteem. Yeah.
That's perfect.
And so this is definitely an area that you think you want to work on. It's one of the things you think you'd like to do.
For sure.
Okay, so that's a little segment of a kind of a role-played interview to show you how it works. So you see, we built the interface to not just to document what's going on, but actually to assist with a motivational interviewing and solution-focused style of interaction. That the interface itself prompts the intervention and vice versa. So it's very important to us. I'll just show this slide to know that we work with coaches to help people set goals that are specific, that they have a kind of measurement, that they're going to be attainable, that they're relevant, and that they have an end date. All those things are important in our documentation. Here's the goals section of the interface. This, again, is an actual client. And so you can see kind of some of the goals that this client has. So this is a client who actually wants to gain weight, who's underweight. And so that's one of his goals, become more knowledgeable about a healthy diet, working out. So these are some broad goals. And under these goals are going to be different action items that the person wants to set to work on that goal during the next 30 days. Here's another, these are two of our health coaches, again, doing a little bit of a role play of the process of goal setting and action items.
My goal long term is to be exercising like in a consistent routine, and I would say 3 to 4 days a week. To your lifestyle, 3 to 4 days out of the week. Yes. Okay. And what does this help Sarah to accomplish? It helps me to have that mental clarity, keep a stable mood, my blood pressure in check. Okay, so the benefits of this are mental and physical for you. Yes, yes. Okay. All right, so I'm typing this up here, and you can tell me if it's resonating with you or if I need to change something. All right, so be consistent with exercise, 3 to 4 days a week of walking to improve health, both mentally and physically. That's it. That's exactly what I'm wanting to do. Okay, wonderful. So like I said, I'm typing this in. I want it to be in your words because you're more likely to stick with it when you feel good about it. So if I'm writing something and it doesn't really, that's not how you would say it, or it's not really sticking you here, we can change it. Okay. All right. So, again, we have a ruler here. So this is progress. So, one would be, I'm still thinking about it. I really haven't done anything. 10 would be, I've mastered it. I could teach somebody else how to do it. I'm doing it so well. Where would you put yourself on a scale of 1 to 10 with this? I would say a 3. Okay. And why a 3? Because I'm not doing it yet, but I really made up my mind to start. Okay. So I kind of started planning for it. Okay. So it's not even on the radar. It's definitely on the radar. You know specifically what you want to do. So that's great that you even know what steps you want to take. Some people say, I just want to work out and don't know what they want to do. You know you want to walk. You know how many times a week you want to do it. Have you thought about how long you want your sessions to be when you go for a walk? Starting for 10 minutes. Okay, if they go longer, great. If they don't, at least I accomplished the 10 minutes. Wonderful. So you've made it attainable and you've made it realistic for yourself with the opportunity to go up more. Yes. Fantastic way of approaching this goal. All right. So the next component of this would be making sure that it's in manageable pieces for yourself. So that's called action steps. So these are small, manageable things that you can do that, like you've already said, are attainable and realistic. So putting this in your words, what do you feel like your first step is? The first step is once a week to go for a walk. All right. So once a week to go for a walk for about 10 minutes? Yes. Beautiful. That looks good to you? Yes, at least 10. Yes. That's perfect. Or at least. So I'll change that for at least 10 minutes. Yes. Wonderful. All right. So looking at that goal, 3 to 4 days a week, you've definitely made it manageable. You're starting with 1 time a week, and eventually you want to move up. Yes.
Okay, so that's a little role play about that section. The following page, so you can see we're just sort of working our way down this black bar on the left here. We looked at the dashboard, we looked a little bit at the goal setting, and here's the action item and reminder section. So again, this is an actual client. These are typical client goals. Finishing Kool-Aid and not making any more, but drinking more water, going to the YMCA 3 times a week, eating protein sandwiches, and so forth. These are the specific action items that then the health coach helps the person to drag and drop these onto certain days when they want to accomplish that. And they may want a reminder about that specific task. So here's the final this is just about a minute little role play clip of setting action items and reminders in this section. So another kind of cool thing that the computer program can do is to send you reminders. And so I have your phone in here. You gave us your phone number last time. And so this first one, this goal for yourself that you've set of eating 2 days a week, eating dinner on a smaller plate, is that something you'd like a reminder of?
Yes.
Or is that something you'd like to... So if we're here on this day, what day would you like a reminder to do that?
On Sunday the 29th.
Okay, so all right. And what would that reminder say if you were going to set it for yourself?
Eat on a smaller plate.
Okay, great. Any kind of little encouragement or anything you want to put in? It's just this for you. It's just going right to you. You want to send a message to your future self?
Yeah, you can do it. I like that.
I'll put a little exclamation point there. And you want this in the morning, in the afternoon, or evening?
Morning.
And then right in the morning.
Yes.
So it's sort of right on your mind when you wake up.
Exactly.
Yeah, great strategy. Okay, so that's a little bit about how that section worked. Just the last couple things. This is the Chatbox interface. So this is just a list of things that this particular client has ordered: a movie tavern gift card, protein mix, a little YMCA membership, and so forth. When we click on this redeem button, it opens up an email that goes right to our MChat order email address, and the health coach just really helps the person to, they go right to Amazon, the person gets to pick the color and the size of things, and then the link is pasted right in the email. We order it, like I said, and ship it right to the person's home address. There's a resources page that I didn't cover, but each of the health areas has a list of resources, community resources that are attached to it. Along the right side of these boxes here, you'll see a little blue deal with a little plus sign here. And if the person likes any of these and wants to be reminded about these, the health coach can click this button, and then what happens is it gets added to the summary report that's printed out at the end. It just gets added at the end of the summary. So just here's a couple little pieces of a summary report of someone who's working on diet and physical activity, and you can see some of their goals were to walk the loop 3 times a week, I guess, the loop, eat healthier, and learn to swim, and so forth. So that's a little bit about the summary report. Now Emily's going to talk a little bit about how we are evaluating and what some of our early outcome data looks like.
All right. Well, as Dr. Walters mentioned earlier, this project is very much the opposite of a clinical trial, in that in most clinical trials you set your plans for what you're going to measure, and you don't stray from those from the beginning to the end of your project. Our evaluation approach is much more similar to kind of a typical business model where we are kind of financially depending on being able to get good outcomes. So we're using 2 different kinds of evaluation methods. One is called developmental evaluation and one is called performance evaluation. In a developmental evaluation, you're using an approach that allows you to make continuous changes over time in order to enhance the design of your project. And at the beginning of this initiative, we knew that similar approaches worked really well with higher income populations, but we didn't know if this approach would work well with a formerly homeless population. So we set the evaluation up to allow us to gather and examine data on a very regular basis so that we can make minor improvements over the course of the project. A performance evaluation is mandated by CMS, the Centers for Medicaid and Medicare, and they have set up these waiver projects to only pay you for the full amount of your project if you achieve certain metrics. So we are very invested in making sure that we are successful so that the investment that our university has made will be paid in full. So both of these evaluation approaches include several key components. Daily wondering for many of us who are involved on a day-to-day basis in the project. We also pull and examine weekly metrics to see where we are for the performance evaluation. We are also sitting on an absolute mountain of data. We collect a lot of different instruments as well as qualitative data through the course of the project. And we've set up a schedule to look at different elements of these data sets on a month-to-month basis. And then periodically we'll take deeper dives. We have a group of researchers who are affiliated with the team, and they take different elements of it and pursue other deeper research questions. So the data flow is as you saw on the screen, it gets entered into the computer, and then that gets entered into a system called Efforts to Outcomes, which is a case management software program that's used all across the country. All of the homeless service providers in our community use ETO, and the MChat data portal was built to sit on top of ETO. So all the data flows into ETO, and then we query it out, and we use Excel, Tableau, SPSS, and SAS to analyze that data. This is an example of a weekly report that we looked at. This weekly report was for the very last week of our fiscal year. And as you can see, we were extremely excited to have reached all of our metrics, our expected metrics for CMS. So what have we learned so far? Permanent supportive housing ends homelessness, but the barriers that people face when they are housed are just tremendous. Because they live in deep poverty, they become extremely isolated. Many of them battle severe depression, and as Dr. Walters mentioned, many of them are battling bed bugs. One of our more recent exciting events was a person dealing with a 3-foot pile of dirt in his living room that some shady contractors left over a week while they were doing work in his home. So the barriers that people face are pretty grand, and very often you might think that these are too large for people to be able to work on higher level goals, like things like diet and exercise. And yet, what we have found is that the population that we're working with is really excited to be able to set these kinds of goals, and it gives them new hope to be able to pursue goals for themselves that, because of their poverty level and other barriers, had not been able to work on previously. So these are some of the examples of the common goals that people are working on: exercise, losing weight, managing their medication. And these are the areas, you remember if the little check boxes show on the screen that those are the areas that people have chosen to work on. The majority of people are working on diet and physical activity, and the third largest area that people are working on is substance abuse, though we include tobacco in substance abuse, so a lot of the people who are working on substance use are actually trying to reduce their smoking. So on average, people are receiving about 1 coaching session a month, which we're really excited because in evaluations of programs for this population, actually achieving monthly home visits is a big challenge. So our coaches have been successfully able to engage MChat clients and continue to visit with them regularly. On average, their sessions are lasting about close to 1 hour. And a little more than a third of people are receiving the text reminders. Many of them have cell phones, but they often run out of minutes and time, so they're not able to do that. So about a third of people are using that feature. And of those, they've set up just about 6 text reminders during the program. And you can see on the screen are some of the sample reminders that they've chosen. So one of the things that we were really excited about with the chatbots is that over half of the chatbots are being used for health and exercise and diet-related items. We often see some of our health coaches and other staff members leaving here with giant supplies of toilet paper and paper towels because, as I said, this population is very impoverished, and they often use their chatbots to purchase things that help meet their basic needs. But once they've been able to get those, they generally seem to be shifting to spending their chatbots on things that will benefit the goals that they've established. And while at the beginning of the program we thought that the chat box might be the most valuable, motivating feature of MChat, as you can see from this slide, what people are finding most helpful is their health coach. We have an incredibly fabulous team of health coaches. They are well trained. They establish very great relationships with their clients. And you can see from these examples that they're really excited about the value of those interactions. If anything, people in their monthly assessments are asking for more coaching visits rather than less. So far, our outcomes are looking really well. We've seen about a 1/3 reduction in depression symptoms, about a 1/4 or so reduction in the number of people who were abusing substances at baseline who are still abusing substances, and that is based on the use of the timeline follow back as well as cheek swab tests. And then we've seen a little more than a 50% reduction in the number of criminal justice interactions. We've also been excited to see that the proportion of people who have moderate to severe levels of depression has dropped pretty dramatically from 59% at baseline to 36% at follow-up. I'll give you a moment to take a look at some of our consumers' own words. An individual said, "I'm on a limited income and the chat box has helped me get a discounted YMCA membership. I'm working with my health coach on good days and bad days. I had a lot of friends who never made it to their 50s like me, and I realize now that I should have been taking better care of myself years ago. I feel like I've been given a second chance." These are common comments that we're hearing, that people are really excited about the transformations that they've been making in their lives. And while we're really excited about this model, we also need to give a big nod to our community partners, without whom this wouldn't be possible. We've had some incredible assistance from the programs that offer case management to permanent supportive housing. They helped us recruit people. They help us engage with people at support groups and maintain ongoing relationships. The YMCA has been wonderful to give us discounted memberships and allow us to meet in their settings. So I think we have time now for some questions.
Hi, yes, thank you, Scott and Emily. Believe it or not, you must have done a wonderful, wonderful job. We have no questions in the Q&A pod at this time. So we'll give people a few minutes to process what's happened and see if they have any questions that they'd like to put out there. Please use the Q&A pod on your screen to put any questions into for Dr. Walters or Emily. And just from my perspective, it looks like the MChat's working wonderfully, and it's interesting to see how depression's decreased so much in folks that are homeless or are being affected with homelessness. So it's a wonderful project that you both are doing. We did have one comment come through from Sandra, who says, "I'm especially impressed with the genuine involvement of participants. For example, how and when would you like a reminder? Respect and empowerment evident."
Yeah, autonomy is a key part of this, and it was very important for us to make this something that people are building with the coach. Yep.
Another question was, well, comment also, great presentation. How long is follow-up?
We'll be following up with people. It depends on when people were, well, it depends on when people were recruited into the project and how long the waiver will last. But everybody is Well, it really depends. Most people are in the project around 18 months, so we'll have 18 months of follow-up. But if the 1115 waiver is renewed for Texas, it may be longer than that. And people complete a major assessment point every 6 months, where they basically repeat all the baseline measures.
Great, thanks. Okay, so another comment came through. So basically, it's case managers who are using this program with the clients?
No. All of these clients have case managers that are affiliated with our local community partner programs. So that allows our health coaches to simply be health coaches and to not have to serve the dual function of being case managers as well.
So the health coaches are the ones that use the interface with people. It's not the clients directly inputting their information. It's the health coach. We have a team of 5 health coaches. We're fully staffed and we're fully built out in terms of clients. So each coach currently has a caseload of 60 clients.
Okay. We had just a couple other comments that came in. Very excited to hear about the evaluation component, the developmental and the performance, as well as great presentation. Thank you. Sounds like a very needed program that works at the change level.
One of our goals in this program was to build something that was a little closer to dissemination. And one of the ways we did that is by starting with a commercially available case management program that's already widely used in the real world. And so our hope is that when we have our final evaluation data or when the waiver ends, then we'll have the health coaching system that can actually plug into a commonly used case management system in the real world.
Which is important. A lot of folks need the practicality to be able to use this in their agencies.
And I'll be honest, ETO is widely used, but it's not ideal for our purposes. But we managed to make it work just because that's what people use. And if this were replicated in the real world, we're going to have to make something that people already use in the real world unless we want to just reinvent the whole thing.
Right. No, that makes complete sense. We did have a question come through. What are impacts of this model for young clients? Example, teens with mental substance abuse issues. Is this model linked in with the public school health program?
Most of the people in permanent supportive housing are age 50 or older. So for our client population is a relatively older population. We have few people who are between the ages of 18 and 35. So I think if you were going to use this model to target a younger population, you'd probably have to do some reconfiguring.
But it does occur to me that I've been exploring this with some different people. So we currently target those particular areas with this population, but I'm just flipping back here. So, what if this were used, let's say, in a criminal justice system, where the areas weren't diet and exercise and social support, they were things that are related to criminal justice outcomes. They were related to pro-social peers and neighborhood safety and pro-social leisure time activities and substance use and criminal thinking patterns. So the progression of the program would be similar, but the areas would be different. Or let's say it was related to cancer screening behaviors, preventive cancer behaviors, in which case you're talking about diet and exercise and health screening, or let's say it were focused on reproductive behaviors, in which case it wouldn't be these areas, it would be condom use and avoiding shared needles and getting tested. And I think that the same progression could work of setting goals, of setting action items, of setting reminders, but that these particular areas might change a bit.
Got it. Thank you.
But kind of the next thing I've been thinking about.
It's the next project on your plate.
Next project.
Um, here's a very good question for you. How do I start MChat in another state?
Emily? Well, so right now, MChat exists in a petri dish because it was designed, we did use, and we use a commercially available case management system, efforts to outcome, but the MChat interface, which is the one that you're looking at now, is created in a petri dish to function under these exact circumstances. So there would need to be a process where this is adapted for a different kind of setting. It were set up in ETO, and are the behaviors right? Are the measures right? How do people get in? How are the health coaches trained? So it's not quite ready to just to hand off. There is still some translational work that would need to be done.
But if you all were able to find funding to adapt MChat for your community, talk to us.
Thanks for the plug, Emily. Yes, that's true. We're funded by a Medicaid 1115 waiver to the state of Texas. And so that's what paid for this, is CMS paid for this under a waiver to Texas. And it certainly could be replicated in another state at probably far less cost than it cost us, but it would still cost something to make that happen.
Yeah, we did build it from the onset with the expectation that it could become replicable. That's why, as Dr. Walters said, that's why it's built onto the efforts to outcome system. But there's really no reason why it couldn't be modified for a lot of other populations. We'd have to have the resources to do that.
Makes sense. Do you guys see sustainability within Texas if CMS doesn't fund it again?
We are seeing really a huge amount of community excitement for MChat, and we're getting such good results. I think that we will be able to find resources to sustain it. But I would think based on the outcomes that we're getting, that CMS will be motivated. We're hoping to want to continue to support it.
If I was a betting man, for your high utilizers in a hospital setting, or for discharge plan with people that are at risk for relapse or for discharge back in the hospital. So it's a perfect sort of light touch intervention for a hospital system in that way.
That's great. Well, it looks like no more questions, or wait, hold on. We have time for last question. Do you ever see working with clients via phone for health coaching?
Yes, actually a third of our interactions are over the phone. They don't look quite like what you saw here. This is the model for an in-person interaction. But in the typical number of contacts with clients is around 2. So a health coach will meet with a client once in person, and then they'll do a mid-month check-in over the phone. And they're different kinds of calls, but they still kind of touch on the same behaviors and progress and how are things going, and how can I be helpful? What do you want to do in the next visit? Have you received your chat bucks purchase? So yes, we do quite a lot of them over the phone. Now the minutes are a problem. It's not a problem to get a phone with a small number of minutes, but if you call your local hospital and are on hold for an hour, then that may be a third of your minutes for the month. And so we find that that minutes are a real problem in terms of getting a hold of people. We are about to launch, we didn't even talk about this, but we're about to launch a phone component where we're going to be giving a phone to a selected number of people and asking people to check in every day. It's an automated system to check on in these different health behaviors that would populate this interface. But that would give us the ability to get a hold of people because we are going to be providing them with phones and free nights and weekends and free T-Mobile minutes, so we can get a hold of them. So we're trying that as sort of a little experiment with a subset of our patients.
That's great. And I want to thank you both, Dr. Walters and Dr. Spence Almaguer, on taking time today to present on MChat. And it looks like we'll have another webinar with you in the future after your telephone event, possibly, to tell us how that all works out.
Sure. Sure, we'll book it.
Sounds good.